In this lecture, we will discuss right ventricular hypertrophy, including its EKG features and potential causes. Hypertrophy refers to an increase in muscle mass. A hypertrophied ventricle is thick and powerful. Ventricular hypertrophy is often the result of pressure overload in which the heart is forced to pump against an increased resistance. Now, just as weightlifters develop bigger and stronger muscles by moving progressively heavier weights, the heart muscle grows thicker and stronger when having to eject blood against some sort of resistance. When the ventricle hypertrophies, the flow of electricity through the heart changes, and so does the axis. Normally, the electrical axis of the heart lies somewhere between -30 and positive 110 degrees. However, if the right ventricle hypertrophies, there will be a greater anterior and rightward electrical forces. Okay, so with right ventricular hypertrophy, we have greater anterior and rightward forces. Okay, here's our right ventricle. This is our left ventricle. Again, our right ventricle and left ventricle. What we're saying here is that it's getting thicker in hypertrophy and getting bigger. Okay, the same thing here in this image over. Okay. Now what we have going on is maybe we have pulmonic stenosis or pulmonary hypertension that's causing an increase in pressure that the right ventricle has to push against, and because of that it gets bigger and stronger. And because of now the right ventricle is taking over, okay, or having greater forces coming its way because of the greater mass, the axis will now shift, okay? And notice in this case the arrow shifted more towards the right, okay, rightward and anteriorly. Here's our anterior portion of the heart. Remember, our right ventricle is the most anterior chamber of the heart, and notice that normally this will be the right ventricle's vector, this one here, but with this additional hypertrophied right ventricle, we get an additional vector, even stronger vector that's pushing towards those anterior and rightward forces. Here's the right side of the heart. Okay, so now let's go through the EKG criteria. So first we have a rightward axis in the frontal plane, which is beyond positive 110 degrees, okay? And that should make sense. We just said that we have greater forces coming this way, okay, towards the right side, and because of that, in the frontal plane, we'll have right axis deviation. It will often be beyond 110 degrees, okay? Normally it's between -30 and positive 105 or positive 110, you may hear. But the thing is, we are shifting everything to this rightward axis, okay, over in this region here. And that's because of those additional stronger rightward forces that are heading that way. Next, we'll see dominant R waves in the right precordial leads, V1 and V2, that will often be greater than 7 millimeters tall and have an R to S ratio that's greater than 1. That is a greater R wave amplitude than the S wave amplitude, okay? So again, now we're talking about those right precordial leads, because we have more forces coming that way. Here's V1, V2. Notice that we now have an amplitude of our R wave. This is the R wave. This would be our S wave. Here's the R wave and the S wave. Okay. Notice that the R wave amplitude from this point until there, in both of these cases, is greater than that of the S wave. So that's where we say we have an R wave amplitude greater than S wave amplitude, or the R to S ratio is greater than 1, okay, because we have a greater R wave amplitude. We also mentioned that those R waves are often greater than 7 millimeters tall, okay, so each millimeter is one of these small boxes, and we can see that's obviously happening here in V1. Okay, so that's one of the criteria. Now in the left lateral precordial leads, V5 and V6, we will essentially see the opposite. We'll see dominant S waves greater than 7 millimeters in depth, okay, and an R to S ratio that's less than 1. That is a greater S wave amplitude than R wave amplitude, okay? So now we're pretty much seeing the opposite. Remember, our forces, we said, are coming in this direction, moving away from our left side. So because they're moving away from our left side, we're going to see greater negative forces or greater S waves. Okay, this is again our R wave and S wave. Here's our R wave and S wave. Okay, and notice in this case, in V5 and V6, our R wave is less than our S wave in amplitude. In such cases, we call this an R to S ratio that's less than 1. Okay, here's our R wave amplitude in each of them. Notice that it's less than our S wave, okay, because our forces are moving away from these leads. Okay, so we'll see more negative deflections in these leads. And again, also the S wave amplitude, which we can clearly see in both of these leads, is greater than 7 millimeters in depth. Okay, now the QRS duration may be slightly longer due to increased ventricular mass, but it will usually remain less than 120 milliseconds. That is, the changes that we're seeing are not a result of complete right bundle branch block. In complete right bundle branch block, you want to see a prolonged QRS interval. Okay, and we don't want to see that here. Now, it's important to note that right ventricular hypertrophy can cause incomplete or complete right bundle branch block, and in such cases, we don't want to use the voltage criteria that we previously just discussed. Okay, so again, if you have right bundle branch block present, do not use that voltage criteria, okay, that we just mentioned earlier. All right, now there are some EKG features that can support the diagnosis of right ventricular hypertrophy. The first one here is P pulmonale, which is a sign of right atrial enlargement. We would see an increase in P wave amplitude in leads 2 and V1. Okay, so just like think about what's going on. Let's erase this so you can see what we have. So again, we have our right ventricle, okay, so we can have some increased resistance from our pulmonary artery, okay, and in that case we can have a backup of pressure. And if this right ventricle hypertrophies, okay, and maybe the chamber becomes even smaller, okay, or can't handle more, you can see blood or pressure backing up into the right atrium. So some supporting evidence could be right atrial enlargement. And one of the things we see is this P pulmonale, where we see an increase in P wave amplitude in leads 2 and V1. So here's P pulmonale, okay, and remember, sign of right atrial enlargement, okay, and in lead 2, what we're seeing is an increase in our P wave amplitude. Remember, the initial portion of the P wave represents right atrial depolarization, so we're looking for an increase in amplitude, okay. In lead 2, we want to see an amplitude at least 2.5 millimeters or greater, okay. We can see it's greater than that here. And then in V1, we want to look at the initial P wave deflection of these biphasic P waves, okay? Remember, this latter portion represents left atrial depolarization. We're looking at the initial portion. In such cases, we want it to be at least 1.5 millimeters or greater, okay? So that's P pulmonale. And remember, pulmonale, think of lungs, pulmonary, and often the times the causes of right atrial enlargement are a consequence or secondary to lung issues. All right, another supporting finding is called right ventricular strain pattern. These are secondary ST segment and T wave changes that arise from repolarization abnormalities secondary to the hypertrophied ventricle. In right ventricular hypertrophy, we see ST depression and T wave inversion in leads V1 to V4, as well as in the inferior leads 2, 3, and AVF, okay? So now we're looking at this right ventricular strain pattern, okay, and that's over here. We're showing that. Again, notice in V1, here's our R wave and S wave. We have a greater R, okay, we'll use another color, greater R to S ratio, okay, so R to S ratio greater than 1. Now with the strain pattern, we're looking at problems with our ST segment and T wave. So notice that there's no issues here, okay. However, in this case, we're noticing that there's ST depression, okay, here's our baseline. Notice we're below baseline, ST depression, and our T wave in this case is inverted. We call that T wave inversion. Okay, so if I just erase that here so you can see, notice that there's ST depression plus T wave inversion. And we're saying that we can see this in the inferior leads as well as leads V1 through V4 with right ventricular hypertrophy. Okay. Now, one thing to note is sometimes with the greater R wave amplitude, the greater the ST depression will be, okay? So the greater forces going up in R wave, sometimes the greater forces that we'll see with our ST depression, okay? So that's something to look for. Next, we have what's called the S1, S2, S3 pattern, which is when there's right axis deviation along with S waves that have an amplitude greater than or equal to the R waves in leads 1, 2, and 3, okay? Now, the finding of deep S waves in the lateral leads, 1 AVL, V5, and V6, also helps support the diagnosis of right ventricular hypertrophy. Okay, so if you look here, just erase that. Okay, now we're looking at those lateral leads, right? 1 AVL, V5, and V6. Okay, notice V5 and V6 are here, and also 1 would be here. Okay, and then AVL up here. All right, here's lead 1, AVLs in this case. So what we're saying here is that we're going to see these deep S waves, okay, in these cases. And these deep S waves will be in these leads. Notice here's our S waves, and they're all deep in these cases. Now, that's another supporting finding. And lastly, we have here an increase in R wave peak time, often between 35 and 55 milliseconds. Okay, so think about one small box. In the right precordial leads, we'll see this V1 and V2. Remember, this is also referred to as the intrinsicoid deflection. It should be less than 35 milliseconds in the right precordial leads. Okay, so again, this increased R wave peak time is also known as the intrinsicoid deflection, which is from the onset of our QRS complex to the peak of the R wave. Okay, so if you imagine here our QRS complex, imagine from the beginning of our QRS complex up until the peak of our R wave, we call this the intrinsicoid deflection, and that duration should be less than 35 milliseconds in the right precordial leads, V1 and V2. All right, and oftentimes this can sometimes be prolonged. All right, so that's one thing that can point to also towards and support right ventricular hypertrophy. All right, in terms of causes, we've listed a few here, including pulmonary hypertension, mitral stenosis, chronic lung disease, pulmonary embolism, in which we can see right heart strain, congenital heart diseases such as pulmonary valve stenosis or tetralogy of Fallot, as well as arrhythmogenic right ventricular dysplasia. All right, let's briefly review what we discussed before we end. So again, with right ventricular hypertrophy, we see an increase in these rightward and anterior forces. Okay, because of that, we see right axis deviation that tends to be beyond 110 degrees. Okay, so remember, in such cases, we're going to see a negative probably in lead 1, okay, and positive in AVF. So it's heading in this region here. Okay, now we'll see dominant R waves in V1 and V2, dominant S waves in the lateral leads, V5 and V6. The QRS duration tends to be normal. Okay, we don't want to see the right bundle branch block changes. Okay, and if you do, you don't want to use the voltage criteria. All right. Now, supporting evidence of right ventricular hypertrophy are the right atrial enlargement, where we see P pulmonale and an increase in P wave amplitude, the right ventricular strain pattern that we mentioned over here. Okay, the S1, S2, S3 pattern, where we see right axis deviation and an S wave amplitude that's greater or equal to the R wave amplitude in leads 1, 2, and 3. Deep S waves in the lateral leads, 1 AVL, V5, and V6, and an increase in the peak time of the R wave, okay, in leads V1 and V2, that intrinsicoid deflection. Well, that's the end of this lecture. We discussed right ventricular hypertrophy, including its EKG features and potential causes. I hope you learned something.